Thank you to everyone for joining us today for the Endo Explained webinar session. Dr. Farr Nezhat is going to begin with some introductions.
Hello, everyone from around the world. Welcome to Explain. It is a pleasure and privilege to have all of you from around the world. The sessions today are going to be conducted by Dr. Farr Nezhat, and here we are going to set some announcements from Mr. Zoe Pennington from the Worldwide EndoMarch with exciting announcements. It is again a pleasure and privilege to have all of you. Thank you. Ms. Pennington.
Thank you again for everyone joining us today. We have a wonderful panel, and to watch previous webinars, you can visit our website, endomarch.org, and go to the webinars session, to the webinar tab at the top. We also released an app called Nezhat Endometriosis Advisor, where you can assess your risk of endometriosis. You can download that app for free on Google Play or in the Apple App Store. Dr. Farr Nezhat will be the host of the session today, and we have a wonderful panel. We have Dr. Michael Lewis, Dr. Stephen Palter, Maria and Mauricio, and also Dr. Shadi Seraji. So we are very excited for today's session.
Hello, this is Dr. Farr Nezhat, one of the co-founder of the Worldwide EndoMarch. And I would like to welcome everybody from different parts of the world this morning, afternoon, at night. The topic of today's discussion is ovarian endometrioma or chocolate cyst. And briefly, we know endometriosis could involve different parts of the body. The most common area is in the pelvis, and endometriosis could be superficial, or we call it deep infiltrative, and in the ovaries could be superficial and commonly could cause cyst, and this called chocolate cyst because they contain old blood and the color is like chocolate. So that is the reason they call it chocolate cyst. The significance of this chocolate cyst, not only issue of the pain, also the issue of the infertility, and also a small chance of becoming cancers. So with this brief introduction, I would like to first start with one of our patients that she had infertility, and Ms. Maria Zarate, my husband Mauricio, that share with you their journey of having endometriosis and going through the infertility, and tell us what was their experience. Maria and Mauricio, thank you very much for your time, and we have the podium for you to tell us about your story. Thank you.
Thank you, Doctor. Hello, everyone. We're Mauricio and Maria. We're really happy to tell you our story because it was quite a journey. Basically, what happened was that we were able to conceive, but after 5 miscarriages, it was 3 years of trying to get pregnant. Actually, they never knew that I had endometriosis because they ran a lot of biopsies and everything, and I could get pregnant, but the problem was that I miscarried like around week 6 to 9, so it was a little bit confusing. We went through a natural pregnancy, then IUI pregnancy, and 3 IVF pregnancies, which we were able to conceive and everything. And actually, around the 4th and 5th, they ran a lot of biopsies, a lot of tests and everything, but they didn't know that I had endometriosis. With each miscarriage, they found a lot of things. At the beginning, it was a thyroid problem. Then it was that I needed blood thinners. Then that I needed probably some prednisone, which it could help. The last 2 miscarriages, I needed a lot of IVIG transfusions and intralipid infusions. But once again, we kept miscarriage every time. So on our 5th miscarriage, Dr. Talibian from CCRM, who helped us through all this journey, told us that even though they ran a lot of tests and none of them showed that I had endometriosis, and I never had pain, I never had anything that they could tell that I had it, she told us, I want you to go with Dr. Nezhat because there's something going on. He needs to have a look at, and he will tell you if he thinks that probably there's some of it. Probably she was super lost, right?
Yeah, there was a lot of confusion around because we had been testing every week for certain things. We had been, mostly Maria, obviously, but her blood was being drawn every week, and then 47 different samples of X, Y, and Z. So I guess from a dashboard perspective, everything looked like it was okay. So we were running out of options in terms of what the cause could be for the miscarriages. And every time we had a miscarriage, we would circle back and sort of reassess where we were, and maybe it's this. So we would tackle that problem, and then another miscarriage. Obviously, we don't want to get into the emotional, painful side of it because we would never end. But being objective, every time that we would come back, and by the time we had our last one, that's when Dr. Talibian sort of went back to square one and says, well, maybe there's something here that I'm not looking at.
Yeah, and it was weird because when they did the egg retrieval, I had a lot of eggs and great quality, and we had really good embryos out of it. So everything looked like we wouldn't have any problem.
Yeah,
right?
and the miscarriages were happening at a stage where it didn't make sense. So we were conceiving, we were there, and then after 6 weeks, 8 weeks, I think the further we got was 9 weeks.
Yeah.
So after 9 weeks, that's when things started to go sour. So yeah, we went with Dr. Nezhat, and then it was a little bit. I don't know, they found basically the source of one of these sources, because I think we needed to go through all of this because at every corner we discovered something new, and then the last corner we turned, that's when we decided to do the procedure, which was done flawless and fantastic. And for us it was very important to see the result because as we mentioned earlier, we were ready to basically give up in the whole process. So when we heard of a positive outcome in terms of endometriosis, by positive I mean when the doctor told us that some of it was removed from the uterus, from the ovaries, and pelvis and anus, we didn't really know the depthness of it or what this could mean, but at least now we knew that there was another variable in the whole ecosystem that was now tackled and taken care of.
Yeah.
So the procedure was done in October. I think
at the end of October.
The end of October. we went back to the doctor, to CCRM with Dr. Talibian early December. And we found out that, you know, in March, that everything was walking in the right direction. And
Yeah, basically, it was amazing because Dr. Nezhat, as soon as he had a look and he figured a little bit of her story, he was like, I'm 95% sure that you do have endometriosis. But I was, no, I mean, they ran a lot of biopsies, and it was amazing because he was, I need to do a laparoscopy. I'm pretty sure, and I'm pretty sure that everything will change with this. Honestly, I didn't want to keep like my hopes up, because after 5 miscarriages, it was a little bit tough. But yeah, like Mauricio told you, we went into the laparoscopy, and fortunately, Dr. Nezhat, he was like, you basically could try and get pregnant without IVIG, IVF, anything. I mean, I didn't want to risk anything, so I did all of it. But I'm like, everyone's pretty sure, like, now we have like a pretty big team of doctors, which we're super grateful. But everyone was like, of course, it was what Dr. Nezhat found. 1 month and a half after the surgery, we were able to conceive again, but this time our baby girl is 1 month old, like after 3 years, almost 4.
Thank you very much, Maria, Maurizio. We are so happy for you. And it is a teamwork with Dr. Talibian and of us, of course. You'll be persistent, and we are very happy for you, and we wish you luck. And at one point, I'd like to see the photo of the Manuela.
Of course, I'll bring her.
So if you don't mind to stay around, so we come back later on if you have any more comments to share. Thank you.
oh,
Yeah,
please,
sure.
please, we'll be in the background, doctor. Thank you, guys.
Oh, thank you. So now we go with Dr. Steve Palter. Dr. Steve Palter is one of the known infertility and reproductive endocrinology physician from Gould IVF in Long Island. And I have had pleasure to work with him for many years. Very scientist, and we share a lot of patients together to discuss with us about his view of the endometriosis and endometrioma and infertility. Steven?
Thank you so much, Farr, and thank you to the organization, you, Cameron, Sina, for inviting me to speak today. It's an honor to be here with you. And thank you, Maria and Mauricio, for sharing your story. I'll try and expand on it from the medical perspective a bit. And I have a unique perspective in that I'm currently the medical director of Gold Coast IVF in New York. Prior to that, I was the clinic chief at Yale University, but I trained both in minimally invasive surgery and was part of the Endometriosis Center and the Laparoscopy Fellowship, but also did basic science on endometriosis and also clinical infertility and IVF. So I have the perspective of both the surgeon, the fertility doctor, the IVF, and the scientist that hopefully I can bring to it. And the one thing that I would say that's really important for patients to know is that not all cases of endometriosis are the same. It's a very enigmatic disease. How it grows and where it grows and how it affects fertility is different in every woman. So one of the dangers of reading blanket statements or articles by people who are experts is if they're looking at just one part, like the blind man looking at the elephant, you see the ear or the tail, you'll get a very different perspective. So you can have some people that have endometriosis that's mainly structurally damaging, others that are mainly inflammatory, and others that are a combination. And then the pain comes into it as well. So my take-home message is that treatment must be individualized, and it is different in every patient. 3 things that are important when we talk about endometriomas. So cysts of endometriosis is what Farr and the group asked me to talk about today. When you see a cyst of endometriosis on the ovary, One of the big controversies in reproductive medicine is, how do you treat that? Do you have surgery? Do you do IVF? Do you do both? And if you do both, in what order? And so 3 crucial things to individualized treatment that I think you have to know is, 1, what other factors are present? Make a full diagnosis. Sometimes people at some infertility centers will jump to the first diagnosis and that's it. So they'll say you have endometriosis, but they haven't fully evaluated the tubes, the uterus, the sperm. And if you're treating it in a vacuum, you're wrong. Or as you heard with Mauricio, they're told it's unexplained infertility and unexplained loss, but endometriosis is a portion. And one of the failings of many IVF centers is they think that IVF just automatically fixes everything, and they don't try and diagnose endometriosis. So we have pelvic exams, ultrasound, and the history of pain or with intercourse or periods are vital clues of endometriosis that's often overlooked. The size and the extent of the disease will affect how the patient is treated. So one woman who has no signs of the endometriosis except for her infertility will be treated differently than a woman who has a very large golf ball or tennis ball sized endometrioma cyst. And what are her symptoms? How bad is her pain? So you heard the story from Maria about this. Farr and I have treated patients where they've had devastating endometriosis and the IVF was not going to work until it was treated. There was one case I remember that we did together where the woman was going to the ER every month in agonizing, debilitating pain. She did IVF multiple times that failed, finally came to me in desperation, thinking that she needed a surrogate and an egg donor. And what I saw was that her fallopian tubes were blocked and filled with blood from the endometriosis and also her ovary. And when she had her transfers, her uterus was filled with blood. I actually called her IVF doctor and said, how could you do this? There was no chance it was going to work. And they said, well, this is inoperable. So it was the best we could do. It may have been inoperable to them, but there was another expert that could treat it. And if the disease wasn't treated, that IVF wasn't going to work. And Farr and I, we worked on this. It was a huge case. And in our first IVF, it was successful. Another very personal case for me was when I was a professor at Yale. My mother had an incidental ultrasound postmenopausal, and they said, oh, you have a little cyst on your ovary. So I said, oh, just send me the ultrasound and I'll look at it. And I said, that looks like a malignancy in an endometrioma. And lo and behold, it was. And her doctor was going to ignore it. So you have to really look, what are the symptoms? What is the patient's whole picture? And does the endometriosis need to be treated? And a huge factor is how many children does that couple want to have and the time frame to pregnancy. So how do we triage between surgery and IVF? Well, here's some big misconceptions that you need to know to make your decision. One, the main effect of endometriosis in most people is on the egg. Now, this is not a blanket statement. So Maria, what you heard was she had good eggs, but it was on her endometrium and implantation. But if you look overall, we now know that the biggest effect is on the eggs. And that came from studies where they used egg donors. If the egg came out of a woman who had endometriosis and went into a woman who didn't have endometriosis, the success rate was lower. If the egg came from someone who didn't have endometriosis and went into a woman who did have endometriosis, IVF usually bypassed it. So the main effect was on the egg. But then we found that you got less eggs, and the eggs were often of not as good quality. So that's the main effect in endometriosis. So surgery initially was done on everyone trying to get rid of these cysts. And then danger reports came out that when you take out the cysts and strip them, you damage what's called the ovarian reserve, how many eggs remain in the ovary. Well, the confusion about this is 2 major things. Not all surgeons are the same. So one surgeon does a very minimally damaging surgery with a careful technique, and another can burn and destroy the ovary and leave the woman in menopause. So surgical technique is important. And then a landmark group of studies came out showing that endometriomas themselves damage your egg supply and your ovarian reserve. So untreated endometriomas even damage your egg supply. So it's not just the surgery, it's the endometrioma themselves. So why would you take it out before or not? Well, the risk of doing the surgery is if the surgeon's skill is poor, you're going to harm the ovary. The cost, damaging the ovary, and delaying time to IVF and having an invasive procedure if you don't need it. On the flip side, there's risks of doing IVF right away. the disease gets worse. The woman can go into menopause, or her endometrioma can rupture. There's inflammation. You can have a failed transfer like Maria had. You can have infection, cancer, rupture, or poorer eggs. So the take-home message that we use clinically when we individualize it is if the woman has debilitating pain and other symptoms or fluid-filled tubes, the surgery has to be done first for life quality and to make the IVF work. If we can't get to the eggs because of the size of the endometriosis, the endometrioma, then surgery will need to be done first. If we're afraid that the cyst is so big, often more than 4 centimeters, that ovary is going to become damaged over the lifespan of the woman, or if she has a lot of pain, or if she wants multiple children and we're worried about the ovary getting damaged, and especially if she's younger, then surgery becomes better. And one of the dangers is, just like there's not skilled endometriosis surgeons, there can be less skilled IVF surgeons who can pass the needle through the endometriosis, spread it, rupture it, or it can even get infected. So my take-home message is, what's remarkable today is almost most patients with endometriosis now, between surgery and IVF, will take home a baby. That wasn't always the case. But women suffer with endometriosis, with pain and infertility, horribly. You need to make that correct diagnosis. You can't just tell them, oh, ignore it, take some Advil, it's in your head. This can be a debilitating disease. And then you individualize for that woman. Is the treatment not working? Change something, fix the disease. And is it big enough that it's going to interfere? And then you triage individually, IVF first or endometriosis surgery first. Or I think that's, I don't want to take more time, but that's my endometrioma worldview in a nutshell for you. And thank you so much for having me here.
Thank you very much, Stephen. We will come back to you, hope you don't mind, after we talk to Dr. Lewis and also Dr. Seraji. You mentioned that the surgery has to be done properly in endometrioma and not to decrease the ovarian reserve. Dr. Lewis, I know Dr. Lewis is a co-director of the chair of his department, and he done minimal invasive surgery fellowship with Dr. Keren Nezhat, and he is the director of minimal invasive surgery in the hospital. Michael, please tell us your experiences. How do you approach endometrioma, treat them? Because it's actually in the chat, one of the questions is one of the patients to remove the endometrioma. How do you remove it? What type of endometriomas do we have? Thank you.
Thanks, Dr. Farr, and thanks, Drs. Nezhat, Sina, and Cameron for inviting me. Dr. Palter, also excellent description and in a nutshell describing everything that really a patient should take home from this. I think, so 2 things that you really pointed on to. Number one is early diagnosis. You know, a lot of the times we have the patients who, if it's not from a fertility perspective, it's the patients coming to the surgeon or a gynecologist for pain. And early diagnosis to get that patient some imaging and, you know, the possibility, if they had failed medical management, to get a diagnostic laparoscopy. But the thing is that, you know, most times, and again, like the story with Maria and Mauricio, is that they did all these tests, they did all this imaging, they didn't see anything. Well, then what happens when you do have a patient who comes to you with that ultrasound showing not a 10 centimeter endometrioma, but a 3 centimeter endometrioma or a 2 centimeter, and they have some suspected pain? What do you do at that point? Do you go ahead and treat them right away? And it always depends on the patient's age. We know that endometriosis is a chronic and progressive disease, and if we don't tackle it from a multidisciplinary approach, this is just going to come back and it's going to get worse. So if we do have, for instance, we have this patient with 3 to 4 centimeter endometrioma, she does have clinical pain, she has failed medical management. Okay, so then what do we do next? In terms for the surgery itself, the best approach, instead of doing a laparotomy or an open incision, is to do something that's minimally invasive, obviously, to decrease the chance of adhesion formation, decrease use of post-op pain meds, and quicker return to their lifestyle, because the whole goal is to improve their lifestyle, but also protect their future fertility. The thing that is, again, what Dr. Palter had mentioned, having a surgeon who can carefully dissect that endometrioma while preserving the ovarian tissue, because the eggs are on the outside of the ovary, on the cortex, and as soon as you get into that ovary, and different surgeons have different tools that they can use. They can use just sharp dissection with the scissors, but there's also a lot of other tools that use cautery, which can cause a lot of scarring, a lot of burning to the ovary. And so you may think that you've had surgery with a surgeon that comes out and says, I got it all, I burnt it, it's gone. But what really they did is that they may have gone in the endometrioma, but they have completely destroyed the ovarian tissue, and in that case, decreased your ovarian reserve. So me specifically, what I've been using, and this is from, again, with my fellowship training with Dr. Cameron and having exposure to a lot of different instrumentation, I use, for instance, for me, I use an instrument called the plasma jet, which again is using a bipolar cautery, but this will decrease if I have to use it, in which I try to use it as minimal as possible. I have less thermal spread or less damage to the ovary. But the main objective when they're taking out the endometrioma is to actually get that cyst wall. If the surgeon were to open up the ovary and just drain out the chocolate fluid or the cyst contents and just leave it behind, and then saying, oh, I didn't damage the ovary, I still preserved it, but I drained it, that cyst is just going to come back and you haven't done anything. You have to take out that cyst wall. And it's very important that you carefully dissect it without damaging the rest of the tissue. So for surgeons, it's very difficult in terms of being able to take out the contents, take out the cyst wall while maintaining that ovarian tissue. And so it comes down to the point where, again, you have to have a surgeon who's experienced to do it, understanding to use minimal cautery, if anything, try not to use any at all, while preserving that tissue. And Dr. Farr, remember it was I believe it was Fertility Sterility, that paper back in '94 describing the different types of endometriomas that exist and how they form, and understanding how in cases where it invaginates into the ovarian tissue and will make it not almost impossible, but almost taking piecemeal little portions of that cyst wall out. And it makes it very difficult to do, but you need to be careful. And as a surgeon, you have to take your time to dissect it and get that cyst wall. Otherwise, you're just going to be back there several months later with the patient saying, my symptoms have returned or my cyst has come back. So I think it's extremely important that, again, like I mentioned, careful dissection, minimal cautery, taking out that cyst wall. These are extremely important when dealing with an endometrioma. And aside from that, one of the things is that, getting to the patient to the OR, and one of the things that I see all the time is that we have a patient who's scheduled for surgery, but they end up in the ER multiple times, or before I've even seen them for consultation, they've ended up in the ER for multiple times. Rule out ovarian torsion, rule out ovarian torsion. That's the common theme that they always think that the patient has in these cases. But it could be that there's a type of inflammatory response. The endometrioma is leaking. I mean, what we see 99% of the times is that endometrioma is stuck. It is fixed onto that side wall of the pelvis, and it is not moving anywhere. And, if, again, the emergency department, doctors who then send to other gynecologists, they have to understand that this is more likely an endometrioma, send it to a specialist, and get them to someone who can operate on them, and, again, take out this cyst without damaging that ovarian tissue. And I think I just see it over and over again. And we have, as a laparoscopic surgeon at our hospital, and I train, I have the privilege of training residents. If you don't know what to look for, you're not going to see it. Unless, when I look back at my training and residency, and we didn't have any specialists in endometriosis, we didn't have anyone who could point out the different colors or what it could look like besides endometrioma. An endometrioma sometimes could look, you can't miss it, but things that are around the ovary, things around the tubes, the uterus, the ligaments, you need to have that experience to do that. And you need to have gone to the proper training in order to properly excise it. And without it, you're left with ending up having someone who's going to take you to the operating room, damage your ovary, claim that they've actually got, that they've taken it, and they've sort of, again, delayed you from then either achieving an improvement in your quality of life or continued infertility.
Thank you very much, Dr. Lewis. for excellent description of the surgical technique and other aspects of endometrioma. In the same line that you and Dr. Palter described the way that endometrioma will present. Dr. Seraji, that she did a fellowship with me, and now she is the faculty of NYU Long Island Hospital. She actually did a research and looking at the presence of the endometrioma, the size, and the stages of endometriosis, because unfortunately some infertility specialists, they say if the endometrioma is less than 4 centimeters, may not be important, and then the patient could try to get pregnant or not do not surgery. But they ignore that this endometrioma could have patient had endometriosis somewhere else. And if we believe that the stage of endometriosis affects the infertility, we should know the size or the correlation of the size and the stage of endometriosis. And she did this research, and I'd like her to briefly tell you about her finding. Dr. Seraji?
Hi, everyone. I'm Shadi Seraji, prior fellow of Dr. Nezhat. I had the pleasure of working with him for the past 2 years. Learned so much from him. Thank you, Dr. Nezhat, for whatever you taught me. Our research was, we did retrospective research. 222 patients were chosen. They were all operated by Dr. Nezhat for endometriosis, and they all had endometrioma. When we look at the sizes, all the patients that they had endometrioma, regardless of the size of the endometrioma, they all had either stage 3 or 4 endometriosis. So we proved that even the endometrioma is a small size, still the patient could have endometriosis anywhere else in the pelvis, and up stage to stage 3 to 4. So many surgeons or so many GYNs or REI, they believe that if the endometrioma less than 3 to 4 centimeter, leave the patient alone. But if the patient has infertility, we proved that the patient could have a stage 3 or 4 endometriosis. So we better consider that. And also the size of endometrioma did not correlate with pain in patients. So the patient could have a stage 3 or 4 endometriosis and still with no pain.
Thank you very much, Dr. Seraji. One of the, as Maria and Mauricio mentioned, the unfortunately patient not being diagnosed and being ignored. And I'd like Dr. Seraji to share with us her recent experiences that she has had, that she has seen some patient come to her and have had pain and they have been ignored. Dr. Seraji?
As Dr. Nezhat mentioned, I recently started practicing. In my residency, I didn't have any formal training regarding endometriosis. I knew endometriosis, but we didn't have any faculty who were specialized in endometriosis. When I had the training with Dr. Nezhat, I learned so much about endometriosis. Now going to my practice, I always ask every patient, even if they're with me for another reason, ask them about the menstrual history, every history, and if I'm suspicious, then I start asking, dig in, and the patient don't always voluntarily share with you all this information. Last week, I had 3 patients, 3 young girls in their 20s, and they all had endometriosis, suffered for years with menarche from endometriosis, and everyone, they've been in other GYNs, I think they were undiagnosed, and they were told that, oh, this is normal, the pain that you're going through is normal. And 2 of these patients, they told me that, oh, my mom and my grandma, they went through the same thing, and we were told that this is normal. it's sad, and I'm happy that I had the experience with Dr. Nezhat, so I know how to diagnose and how to help these patients.
Thank you very much, Dr. Seraji. Maria and Mauricio, I'd like to ask you, if you don't mind, one question. If you know you have gone through this journey, and fortunately, Dr. Talebian, excellent physician, referred you to us, and we took care of you, and you got pregnant. What messages you could share if you tomorrow meet a couple that they have got the same experiences and they didn't get pregnant? What do you have to tell them?
So I would tell them that one, chemical pregnancy is normal, unfortunate, but normal. But two, miscarriages or chemical pregnancies are not normal, that they would need to step it up a little bit. They will have to have a look. For me, if I would do it all over again, I would probably have a look at endometriosis a little bit sooner than when we did, right? I think it's important for me to say that I didn't have any pain at all, that I was regular on my cycles. And unfortunately for me, the way that I found out that I had was 5 miscarriages and almost 4 years later. So I think that, like, women shouldn't wait that long. And it's, yeah, basically it's amazing that after almost 4 years, 1 month and a half after the laparoscopy, I was able to conceive, and 9 months after give birth, finally. Like, so for me, that would be, I don't know what.
Yeah, just to build up on what Maria said, I guess that I hope that people don't have to go through trial and error, because the error has a lot of value, sentimental value, and economic value also. So I would really encourage people out there to take control of how they think they're gonna start whenever they start thinking about reproductive cycle. And definitely this should be step one, honestly. People talk about Planned Parenthood, people talk about how to make the most out of your life, but whenever you're thinking about evolving as a family, definitely redefine your step one, because you get it right from day one, you can really save yourself a lot of unnecessary turns or painful ones.
Yeah, and I don't think that it's gonna take them, like, I mean, I went through 4 biopsies, like, without anesthesia, without anything. And you, doctor, I mean, I didn't go through any of that for you to know that I had it, right? So it's worth it just to have a look, just to see, like I was saying, like, 1 chemical pregnancy is okay, 1 miscarriage, it happens. Like, everything has a timing and everything, but 2 or 3, that's not normal. So
Farr, if I could add, that's really important what you guys just shared. And an important message is that not every physician is going to make the diagnosis the same way or do the same tests. So people often come and say, I've had everything done, I don't have this or that. And the panels of diagnostic tests, or even the interpretations, vary greatly. You could go to a mechanic to get your car fixed because they hear something rattling and they replace the wrong part 10 times until you find the right one. Who knows? So we've seen people with endometriosis on ultrasound that's been ignored. And if you have unexplained infertility, sometimes you need to look deeper and it's endometriosis or another disorder. Or if you're doing cycles of IVF and it's not working, don't just repeat the same thing over and over. Dig deeper and get a detective to figure out there's always a cause. You just haven't found it yet.
Correct.
Totally. Yes. Yes.
Thank you very much, Maria and Mauricio and Dr. Palter. So I just want to summarize this, so what we have learned so far, that endometriosis is a very enigmatic disease, and the only way to diagnose is to think about it. And if you have infertility and you have done all of the work and has failed, ask your physician that could be endometriosis. And don't be satisfied by only saying, oh, you don't have any pain, because as you saw, Maria didn't have any pain and she had endometriosis. Or we did the ultrasound and the ultrasound didn't show endometriosis. So these are not adequate. As Dr. Palter mentioned, you have to individualize each person. You have to find a physician to listen to you and go over every details. And you also participate in your health and tell them about your history. Like Maria, I had this miscarriage. And Maria exactly says, it's one miscarriage, one could be accidental, but 2 or 3, there's something wrong. And then pursue it. And then find the right physician. I am oncologist, and we spend a lot of time training, 3 years of fellowship, sometimes 4 years of fellowship in cancer. But unfortunately, we are not training enough physicians to properly evaluate the patient for endometriosis, which is at times actually more complex than cancer. And then when it comes to the treatment, also find the right physician to treat, to diagnose the endometriosis, treat the endometriosis properly, because endometriosis could sit on the bowel, on the bladder, the ureter, and a lot of physicians shy away from tackling them, maybe rightfully, because they should not do it, because they could create complications. They could get to the bowel or cause complication. So you find the right physician, it is important. And when it comes to the ovaries, also, I just briefly mentioned that unfortunately, a small percentage of this ovarian endometrioma could become cancerous. There is a questions on the chat that you use birth control pills for treatment of the chocolate cyst. At the present time, the only effective treatment for chocolate cyst is surgery. We do not recommend any kind of hormonal therapy that before treatment of the removing the endometrioma. That is period. That is very clear, because as Dr. Palter mentioned, endometrioma itself could chew the function of the ovary. So the sooner you remove the endometrioma, even if you don't want to get pregnant, you save the function of the ovary. So this endometrioma, it is 2 centimeters, 3 centimeters, 10 centimeters, has to be removed. Not only to preserve the function of the ovary, because some of them could become malignant. And also it has to be removed, sent for pathological evaluation to be sure there is no ATPO, we call it precancerous condition on that ovary. Now, after the endometrioma is removed, that is different story. After endometrioma is removed, if the patient wants to get pregnant, that is the best time for her to go back and get pregnant. Again, we believe you have to work with a multidisciplinary approach. I am not infertility specialist. I do the surgery, and immediately I will send my patient, Dr. Palter, Dr. Talebia, all the colleagues that they have referred the patient to me. And I tell them, you have to hurry up. Even if you are not ready to get pregnant right now, you may want to go and do some egg freezing So frequently we consult our patient to have egg freezing. If they have partnered with embryo freezing, to transfer it later, because unfortunately age is against the patient. So that is important to work in a multidisciplinary condition. After the surgery, if the patient doesn't want to get pregnant, then yes, we put the patient on low dosage of the birth control pills. They could tolerate it because we have published this paper, as Dr. Lewis mentioned, that original of the large endometriomas are ovulation. And because endometriosis interferes with the function of the ovary, and this corpus luteum, or the ovulation cyst that's supposed to disappear by the end of the month, would not disappear. And that by time this becomes endometrioma. So if you put the patient on suppressive therapy, in the kind of the hormone that suppress the ovulation, and follow that patient, she would not form the endometrioma. That has been our experience for many, many years. And this is what we advocate to do. So that was on the chat. There was a patient had asked that she had endometrioma and may not be treated properly. As Dr. Lewis again mentioned, you have to, and Dr. Palter, you have to identify the cyst. The adhesion has to be lysed and properly take care of the endometriosis to not only treat it properly, also decrease the risk of coming back. So one issue is that sometimes the patient asks about the cancer. Fortunately, the risk is very low, but we always recommend if there is any endometrioma and has to be followed by the ultrasound and MRI if you don't want to operate. I guess, as I said, our philosophy is that endometrioma has to be removed no matter what size it is, and treat endometriosis other area. As Dr. Seraji mentioned, our research shows any patient has endometrioma, no matter how big it is, this patient have a stage 3 and 4 endometriosis and has to be completely treated to decrease the chance of coming back, to decrease to helps the pain and also infertility.
Farr, can I add one thing? It's important that you made me think of. There's a big trend in a lot of IVF centers now to just use a blood test to try and diagnose endometriosis if a cycle has failed, and then they use medications to treat it. And this is not as accurate as a diagnosis as surgery, and it is not the same treatment. And especially if there's an endometrioma, there's, just as you said, Farr, there's no medical therapy that's going to address an endometrioma. But this is a trend from a lot of centers where the IVF doctors don't have experience with surgery. So when you talk about the multidisciplinary approach, you know, a good question that someone can ask their doctor is, how often, when you see a patient with endometriosis in your IVF center, how often do you do IVF and how often do they do surgery? And if the answer is 100% of either one, then it's not right. There should always be an individualization and a combination.
Thank you very much, Dr. Palter, bringing this issue up, because frequently we see patients, I'm sure you see it too, that a lot of IVF physicians, they, in spite of endometrioma, they proceed with the IVF. Dr. Lewis, you mentioned that many possible, one of the possible side effects of the endometrioma could be infection. Can you elaborate in that topic, that sometimes the endometrioma could get infected?
So there's like two different scenarios, and I've had experiences in cases where patients have developed an abscess in an endometrioma on itself, but then also, like, we usually have, I think it's one case every maybe 2-3 months, presents to the emergency department having undergone egg retrieval and had an endometrioma and came in with an abscess that had formed within that endometrioma. And that could be, I mean, again, every case is a little bit different, but it could be a surgical nightmare for that, for both from the surgeon's perspective and also for the patient, because the fact that that ovary now is infected and has become an abscess, it is extreme. It's number one, it could be life-threatening to the patient, where the infection can spread throughout the body. And in a lot of cases, when you have a tube ovarian abscess secondary to an endometrioma that can get infected, most times you have to try to drain it with IV antibiotics. And if that doesn't work within, if the patient doesn't have a response, then you have to go in surgically to remove it. And those cases have a very high chance of having complete removal of that ovary and tube on that side. And so these are some of the risks of having an endometrioma that can sit and grow and get bigger and larger. And again, the fact that, an endometrioma, can happen, you can have an endometrioma with stage 1 disease or stage 2 disease versus stage 3 and stage 4. Having an endometrioma that is associated with a later stage of disease, 3 and 4, involving your intestines, your tubes, your ovaries, that makes it even more difficult than surgically to remove it, where you have a much higher chance of recurrence. As I mentioned before, we try to meticulously to remove that cyst wall, otherwise the recurrence rate is going to be a lot higher. And I think someone had mentioned that in the question and answer about having a laparoscopy, the cyst was told to be removed and it came back right away. Again, it depends on the stage of disease that the patient had, the experience of the surgeon, because again, the more complex or other things that are happening inside the pelvis at the same time, it can make it a lot more difficult to resect the ovarian cyst wall completely. So it's, again, it goes back to, should we remove the endometrioma? And again, as you mentioned, we should be removing all of them in the case of patients are going to have IVF and you may have an infection that happens. I mean, these are some of the things that need to be explained to a patient prior to undergoing an IVF cycle with an endometrioma, because if they don't understand those risks of it happening or don't understand the consequences of having an infected endometrioma and then losing that ovary, then, from a psychological aspect from the patient, I mean, this is detrimental to them.
Michael, that's so important that you said that, because when we do an egg retrieval, the needle goes through the vagina and the vagina has bacteria in it. And if that needle enters the endometrioma, you're introducing bacteria into a perfect closed space for it to grow. And, thank God, I'll knock wood, in 30 years, I've never had an infected endometrioma from an IVF cycle. But if I think my needle is going to have to hit that endometrioma to get the eggs out, I'm going to want that patient to, in most cases, have it removed beforehand. And I'll map the endometrioma to make sure when I get the eggs, I don't get through it. But I know some people just put the needle through it or even try and drain the endometriosis vaginally. And that's when those complications, I think, will go up. And that, you're right, that should be something we try with everything to avoid.
Right.
Thank you very much, both. That is very important points that when you, if a physician, I have seen frequently that Palter send the patient, even he calls me, he cares about his patient so much that he picks up the phone and says, Farr, I cannot reach this ovary without getting to the endometrioma.
Right, yeah. Get it, right.
He pick up the phone, he calls me, he says, Farr, you should go and take this endometrioma out, because he doesn't want to get to the endometrioma. And exactly, he doesn't want to have the same scenario that happens to Dr. Lewis.
No one should lose their ovary having an IVF for endometriosis. That should be once in a lifetime that you see that.
And then in the chat, there is some question that can you distinguish between the functional cyst and endometrioma? I think you agree with me, if you have your experience, infertility specialists could distinguish between the functional cyst and endometrioma. And there's another question in the chat that the infertility specialist recommended to aspirate the endometrioma. No, we don't. Definitely, we don't recommend to do that one, because not only a chance of the infection, as was mentioned, it will come back.
It's going to come back in a month.
And also a small risk of the cancer. I have had patients that actually we reported the case that the patient had few cycles of the IVF and had that cyst that had cancer in it. And finally, she came to us and we fortunately took care of the endometriosis, took care of the cancer, and we saved the ovary. and she went back and she got pregnant and had successful pregnancy, fortunately. So to answer the question on the chat, no, aspiration is not good. It could distinguish between functional cysts and endometrioma and has to be properly treated.
Or one of the reasons why some IVF centers will say don't operate on endometriomas, because they'll say that the ovarian reserve will drop. And you can measure that with a hormone called AMH. But as I mentioned earlier, the study said that if you have an endometrioma and you don't do surgery, it can drop as much as 25% within 6 months. So the fear of damage to the ovary doesn't come just for surgery. It comes from the endometrioma also.
Thank you very much. So we are getting close to the end of the talk. Dr. Seraji, do you have a last comment? Or then you go to Maria and Michael and Steven. Dr. Seraji?
No, thank you. Thank you for having me.
Thank you very much. Maria and Mauricio, do you have a last advice? First of all, I would like to thank you, both of you. But do you have any last comments for the session?
No, basically, like I was saying, I would like to encourage the couples that have been struggling with fertility to don't wait too long, or don't wait for an awful experience to go and check out whether or not they have endometriosis. It's once you have had it, it's pretty common to get to know women that are like aware of everything about this.
Yeah. Yeah, and trust the process, I guess. It's doctors know what they know. Unfortunately, with endometriosis, you as a patient, you're operating in a black box. So talk to your physician. It's there, it happened. We had 2 out of 5 or something, I don't know, but it was there. And whenever it was removed, things started to work. So obviously, I want to thank all the doctors that helped us get this process, and it's worth it. So hang in there, guys, and definitely try your best, because having a baby it's such a blessing.
Thank you very much. Thank you very much for all the panelists. Towards the end of the session, I will ask Dr. Keren Nejat. Actually, he's in the airport. He's flying to Africa to do some charity work and to give the last talk. Cameron?
He is in the airport, so I will say a few words for him. Please be sure to follow EndoMarch on TikTok, Instagram, Facebook, and Twitter to stay up to date on all of our news and announcements. We have a lot of exciting things planned for the 10th anniversary. That will be in March of 2023. So make sure you follow us there to stay up to date. Thank you again to everyone for joining us today. It's been a wonderful session. I'd like to thank the host, Dr. Farr Nezhat and Dr. Keren Nejat, and all of the panelists, Dr. Seraji, Dr. Palter, Dr. Lewis, and of course, Maria and Mauricio for sharing their story as well. We will have another session next month, the last weekend of October, so make sure you register for that one.
Thank you so much.
All right. Have a beautiful weekend. Thank you very much.
Thank you for doing this.
Bye-bye.
Thank you.
Thank you very much.